Let's turn again to anatomage, which will give us a great visual review of the lower limb from hip to toes. We'll start with the bony anatomy as the framework for the muscles. The bony pelvis is a composite made of the two hip bones plus the sacrum and the coccyx. Each pelvic bone has what we call an auricular surface that attaches it to the auricular surface of the sacrum. And those form the two sacroiliac joints that we see here. Each hip bone is composed of the ilium, the ischium, and the pubis regions. Let's take a look at those three-dimensionally. The ilium is the large upright blade portion, and the ischium is the more inferior portion. The pubic bone is the more anterior portion. And together they form like a ring-like structure. So the top of the rim of the pelvis is that pelvic brim that separates the false pelvis from the true pelvis. And there would also be, in addition to this pelvic inlet, a pelvic outlet more inferiorly. Let's look at a couple of landmarks. The obturator foramen, the largest foramen in the body, is in each of the pelvic bones, and we can see the anterior superior iliac spine and the anterior inferior iliac spine, which are both muscle attachment sites. We see the ischial tuberosities, or sits bones, as they're sometimes called, projecting posteriorly and inferiorly. And we can see the pubic symphysis, a fibrocartilaginous joint between the two pubic bones, as well as the sacroiliac joints. To complete our study of the hip joint area, let's take a look at the ligaments of the hip and the pelvis. We can see the inguinal ligament, which I liken to the rolled hem of the oblique muscles. And if we turn posteriorly, we can see the sacrotuberous ligament that joins the sacrum to the ischial tuberosity, as well as the underlying sacrospinous ligament. We can also see the ligaments of the hip joint. Here's the ischiofemoral ligament posteriorly, and as we cruise around anteriorly, we see this iliofemoral ligament with its Y shape, and then the pubofemoral ligament. All three named for the parts of the pelvis they attach to the femur. Now let's take off the pelvis and focus on the femur. Anteriorly, we see the head of the femur sitting in the acetabulum or hip socket, and then we see the greater trochanter laterally, while the lesser trochanter is more posteromedially located. The shaft of the femur is smooth, and we come down to these rough areas, which are called the epicondyles. There's the medial epicondyle and the lateral epicondyle. We see the patella sitting on the patellar surface of the femur. So if I take the patella off, we can now look at the posterior femur. And again, we see the greater and lesser trochanter with the intertrochanteric crest just distal to the constricted neck of the femur. We can see the gluteal tuberosity and the pectineal line forming that linea aspera on the posterior femur, a major muscle attachment site, and how that kind of expands to form the flat popliteal surface between the two femoral condyles, with their intercondylar fossa between them. So let's stay posteriorly and look at the tibia and the fibula. We can see the flattened tibial condyles with the intercondylar eminence between them, and that's the attachment site for the cruciate ligaments. And we can vaguely see the soleal line where the soleus muscle attaches, and how the tibia ends distally with the medial malleolus that projects down over the talus of the tarsal bones. If we look at the fibula, we can see the head of the fibula is proximal, the shaft, and then the lateral malleolus flanks the opposite side of the talus. And there'd be an interosseous membrane connecting these two bones to help support the leg region. If we look anteriorly, we can see the tibial tuberosity for attachment of the quadriceps tendon, the sharp crest of the tibia down its anterior border, and again ending in the medial malleolus, which is part of the tibia, and the lateral malleolus is part of the fibula. Let's take a look at the ligaments of the knee joint, a commonly injured joint in the body. If we look at the medial aspect, we can see the medial collateral ligament. Remember, it's attached to its meniscus. If we turn laterally, we can see the lateral collateral ligament attached to the head of the fibula. And if we go posteriorly, we can see the posterior cruciate ligament as well as the anterior cruciate ligament. Now, let's remove the patella and the femur and tilt up so we can get a look at the menisci. The lateral meniscus is more O-shaped. The medial meniscus is more C-shaped and is attached to its medial collateral or tibial collateral ligament. We can see how the menisci sit atop the tibial plateau and flank either side of the cruciate ligaments, anterior and posterior. Moving down to the skeleton of the foot, we see 7 tarsals, 5 metatarsals, and the phalanges. Among the tarsals are the talus, and that's the one that's flanked by the lateral malleolus of the fibula and the medial malleolus of the tibia. And if we follow down this medial edge, we see the navicular and the medial cuneiform, or first cuneiform as it's sometimes called, the intermediate or second cuneiform, and the lateral cuneiform or third cuneiform. If we turn the foot so we can see a lateral view, we can see the calcaneus, the largest of the tarsal bones, as well as the cuboid, which is in line along that lateral edge of the foot. The metatarsals, 1st through 5th, Roman numerals typically designate them. There's a base, a shaft, and a head on each. The big toe has 2 phalanges, a proximal and a distal, while each of the other toes has a proximal, a middle, and a distal phalanx. We can also see the 2 sesamoid bones on the sole of the foot. These are 2 tiny sesamoid bones that grow in the tendon of the flexor hallucis brevis muscle. Let's take a look at the retinacula and the ligaments of the ankle joint. We can see the inferior extensor retinaculum with its Y shape and the superior extensor retinaculum. And if I remove those, we can now see the ligaments of the ankle joint. The ligaments of the lateral aspect of the ankle attach the fibula down to various tarsal bones. Here's the anterior talofibular ligament and the calcaneofibular ligament, as well as the posterior talofibular ligament. And those are the weaker bands, which is why more people over-invert than over-evert. If we look at the deltoid ligament of the medial aspect of the ankle, we can see the posterior tibiotalar ligament, the tibiocalcaneal ligament, the tibionavicular ligament, and the anterior tibiotalar ligament. Those comprise the stronger ligaments of the ankle at its medial aspect. So that concludes our study of the bones of the lower limb. Now that we've covered the bony anatomy of the lower limb, let's tackle the muscles using the anatomage system. Let's take a look at the gluteal muscles. We see gluteus maximus, and we can barely see the underlying gluteus medius. So let's remove gluteus maximus, and we can see gluteus medius in its entirety. Now, gluteus maximus is a powerful extensor of the hip joint. Gluteus medius is more of an abductor because of its lateral placement. And if we remove it, we can see the gluteus minimus muscle. Gluteus minimus and medius have about the same origin and insertion, and they have the same action. If we remove gluteus minimus, we can see the piriformis muscle coming through the greater sciatic foramen, and we can see the superior gemellus, the inferior gemellus, and the obturator internus, which sends its tendon between the two gemelli muscles. The last in our series of lateral rotators of the hip is the quadratus femoris. If we remove these, piriformis, superior gemellus, obturator internus, inferior gemellus, and quadratus femoris, we've covered the muscles of the gluteal region. If we transition to the posterior thigh, we see the hamstring muscles. And remember, they take origin off the ischial tuberosity. We can see laterally the biceps femoris muscle. It has two heads. The long head comes off of the ischial tuberosity, while the short head comes off of the linea aspera at the posterior thigh. It transitions laterally to the fibula, whereas the other two muscles of the hamstring group, the semitendinosus muscle with its cord-like tendon, and the semimembranosus muscle, which you can't tell from here but has a broad, flat, shear tendon. Those are the two muscles of the hamstring group that attach medially to the proximal tibia. If we take those off, we see deeper muscles that belong either to the anterior compartment of the thigh or the medial compartment of the thigh. After covering the muscles of the posterior thigh, the hamstrings, we see muscles of the anterior thigh. And let's start proximally with the psoas major muscle that crosses from the lumbar vertebrae down to the lesser trochanter of the femur, and iliacus muscle that combines with it to form what's often called the iliopsoas because their insertion is really indistinct. If we remove psoas major and iliacus, we see how the iliacus muscle filled that iliac fossa. Now, if we look at the muscles of the anterior thigh that are located more within the thigh, we see sartorius crossing from anterior superior iliac spine down to the medial tibia. It's in the area known as the pes anserine zone, remember, we'll come back to that. If I remove sartorius, we can see the muscles of the quadriceps femoris group. The quadriceps femoris group combine to insert on the tibial tuberosity by way of this patellar ligament. Let's remove the quadriceps femoris muscles. The rectus femoris is the only one of the four that crosses the hip joint as well as the knee. And then we see vastus medialis, vastus lateralis, and now we can see the vastus intermedius that's deep to the rectus femoris muscle. Those four muscles, like most muscles of the anterior compartment of the thigh, are supplied by the femoral nerve. If we remove vastus medialis, we see one of the remaining muscles of the anterior thigh, and that is the tensor of the fascia lata. If we remove gracilis, we see the pectineus muscle, Pectineus is the more lateral muscle of this medial compartment group. If we remove pectineus, we can see the adductor longus muscle, which has deep to it the adductor brevis muscle, and deeper still is the adductor magnus with its adductor hiatus that allows the femoral artery and vein to pass posteriorly to become the popliteal vessels. And now we can see the continuity of adductor magnus with the hamstring muscles, because there is a hamstring portion of adductor magnus as well that attaches to the ischial tuberosity. The remaining muscle of the medial compartment of the thigh is the obturator externus muscle. The muscles of the medial thigh generally adduct the hip joint and are supplied by the obturator nerve off of the lumbar plexus, while muscles of the anterior thigh will either flex the hip if they cross the hip or extend the knee and are supplied mostly by the femoral nerve. If we focus in on the pes anserine region, remember with regard to the thigh, that's a place where one muscle of the anterior compartment, a muscle of the medial compartment, and a muscle of the posterior compartment all converge. We see sartorius and gracilis and semitendinosus from the posterior compartment, all converging at the medial tibia. Now let's transition below the knee to cover the three compartments of the leg. And remember, the leg is specific to the region between the knee and ankle. The three compartments are anterior, lateral, and posterior. We can identify the tibia, and just lateral to it is the tibialis anterior muscle. We can see it passing medially at the ankle. And then adjacent to that, we see the extensor digitorum longus, with its tendons going to the four smaller toes. And then between the two, we see extensor hallucis longus passing to the great toe. And all these muscles are supplied by the deep fibular nerve. Most people have a peroneus tertius muscle, but this individual does not have a peroneus tertius. It is a variable muscle. Now, if we move to the lateral compartment, we can see the fibularis longus passing down laterally, going underneath the sole of the foot to attach to the base of the first metatarsal. And then deep to it, we see the fibularis brevis, which attaches down to the tubercle on the fifth metatarsal, near where the fibularis tertius would attach if it were present. Switching to the posterior aspect of the leg, we have two groups of muscles. There's a superficial group, which includes the gastrocnemius, and deep to it, we can see the soleus. Typically, you can see soleus from either side of gastroc. Now, gastroc crosses the knee and the ankle, while soleus crosses only the ankle. We'll remove the gastrocnemius so we can see all of soleus and how these tendons converge as the calcaneal or Achilles tendon. And if you remember, there is a variable muscle, a standard muscle of variation in the lower limb, and that is the plantaris muscle. Its long tendon can be used in a tendon graft if necessary. It crosses the knee, and all of them converge and insert on the calcaneus of the sole of the foot. With the three muscles of the superficial group removed, we can now see the four muscles of the deep posterior leg. We see the flexor hallucis longus, which ironically is positioned on the little toe side, but its tendon goes to the great toe side. And then medially, we can see the flexor digitorum longus passing to the lateral four toes. And those tendons cross at the ankle and make an X that supports the medial aspect of the arch. Between the two, if we take those off, We now see tibialis posterior, which comes down and inserts deep into the foot and takes part of its origin off the interosseous membrane. The last muscle of this deep posterior group is the popliteus. It only crosses the knee joint and serves to unlock the knee when we're standing with our knees locked. All of these muscles of the posterior leg are supplied by the tibial branch of the sciatic nerve. To complete our study of the muscles, let's look at the foot. We can see the dorsum of the foot, which remember is the top of the foot, has a couple of smaller muscles on it. We see the extensor hallucis brevis muscle and its partner, the extensor digitorum brevis muscle. Those will help extend the toes and are both supplied by the deep fibular nerve. If we turn over to the plantar surface, now we can take a look at the complexity of the plantar surface of the foot. We'll start by looking at the plantar aponeurosis. Remember, an aponeurosis is a broad, flat tendon, and this is where some people get plantar fasciitis. If we remove that, we can see the first layer of muscles. Remember, 3 muscles in the first layer. At the little toe side, we have abductor digiti minimi. Then we have abductor hallucis on the big toe side, and between them, we have flexor digitorum brevis. If we remove those, we see the muscles and tendons of the second layer of the foot. The tendons are important to support the arch and also serve as muscle attachment sites. Here we see the tendon of flexor digitorum longus going the long way to the distal phalanges, and we see the tendon of flexor hallucis longus going to the great toe, and how they make an X that helps support that medial aspect of the arch. But important to that second layer, the flexor digitorum longus is the attachment site for the lumbrical muscles of the sole of the foot, as well as being the attachment site for quadratus plantae. Second layer of foot muscles has 2 muscles and 2 tendons. If we remove those, and I'll remove the tendons as well, we now see the muscles of the third layer of the foot. And there's 3 muscles here as well that kind of mirror that first layer. On the big toe side, we see flexor hallucis brevis. That's the muscle in which its tendons, the sesamoid bones, grow into. And then on the little toe side, we see flexor digiti minimi. And between them, we see this 7 or L-shaped muscle called adductor hallucis. Those are the 3 muscles of the third layer of the foot. Take off flexor hallucis brevis and see those sesamoid bones, flexor digiti minimi, and adductor hallucis. Now what's left are the 2 muscles of the deepest layer of the foot and the 2 tendons that belong, and those are the plantar interossei and the dorsal interossei. If we remove those, we can see the 2 tendons that are an important supportive part of the sole of the foot's deepest layer, and that is fibularis longus, which crosses all the way from lateral to medial, as well as the tibialis posterior tendon. The complexity of the foot is one reason some of us have trouble standing on our feet all day. I truly hope this series has helped illustrate the wonders of the human body's musculoskeletal anatomy, its architecture, performance, and its amazing detail. Now, to close this course, let's talk again about how we know what we know about anatomy. Gone are the days of the resurrection men who plundered graves so that anatomists and medical students could have a first-hand look. In those days, medical students studied from books, and when it came their turn to work with a cadaver, the group of students would sometimes dissect around the clock, racing against the decomposition process to learn as much as they could, as fast as they could. Beginning in about the mid-20th century, the donation of organs for transplantation and full-body donation for scientific study became sanctioned by a variety of legislative acts and policies around the globe. In the United States, for example, we have the Uniform Anatomical Gift Act that began in 1968 and has been revised throughout the years since. Here, organ donation can be designated on a person's driver's license, and the resulting life-sustaining transplants happen each and every day. But there are also countless body donation programs around the world that help advance medicine and train its future practitioners. The cadavers I use in my courses are used twice for teaching. First, they're embalmed by mortuary science students, and then they're dissected by future healthcare professionals. Our body donation program allows only the individuals themselves to will their bodies. Not even a family member can make that decision for them. And in my opinion, this selfless act is one of the last good deeds a person can do on this earth. So I'll close this series by thanking the many individuals who have honored the future of healthcare by donating their remains to science.